Within communities, acceptance to any service depends on how adequate the information is, what they feel about potential risks, and if they have had any contradictory information. Sometimes there are cultural myths and misconceptions about a service. So the barriers that we often find is where there have been cultural misconceptions, or where we are dealing with women who have not had much access to formal education or even access to basic information about reproductive health and family planning. So those are best addressed through appropriate communication, education, and empowering them to be able to make their own choice. Well, the choice about family planning is to empower women and families in general to make or to be able to achieve the desired spacing, timing, and number of children they wish to have. So when they're not able to have the method they best prefer or that is best recommended, then either they end up with a method that is not very, very suitable, or that's not very convenient. Maybe they wanted a longer term method, they get a shorter term, so they need more frequent visits for subsequent methods. Or, it reduces their interest and motivation to keep using the family planning method. And that, of course, may have the impact of having an unwanted or ill-timed pregnancies. There's a lot of desire to, one, expand the scale of or scope of services provided, increase access, reach out more women and families, have all methods available, assure quality. Now all these create the needs for training and capacity building of health workers to keep updating their skills, knowledge and skills in family planning service provision. We have need for more health workers in a faith-based situation, particularly in Kenya, where we have to also finance the cost of health workers, pay their salaries and benefits with resources that we generate from service delivery. We are constrained by the number of health workers we can have. So we need more health workers. We need training on a continuous basis, upgrading skills. We need financial resources, particularly to support logistics to enable health facilities to go out to reach out to families where they are. We strongly believe that family planning should not be a service provided in a hospital or health facility only, because people are not sick. People need to be empowered. To have this service is a preventive, health promoting service. So we strongly recommend being able to reach out, outreach services, go closer to the homes, take the message out there, provide information, create demand, and provide some services there, and then refer to the health facility for those that require a hospital setting. So we need finances for that. We need to improve our information system so that we can document more, document better, be able to plan well in terms of the commodities demand and match that with the supply system. So the health information system is the other area. And then, community mobilization. We need a lot of continuous information provision on the value and benefits of family planning, on the options, addressing some of the myths and misconceptions. So the whole area of information and communication.